But women have men in their lives, and usually men are going to be, we're going to procrastinate and postpone and not go to the doctor. So I think it's really important for women to know these things about prostate cancer in general anyway, since that's the most common cancer that affects men in the United States. So that's why I was going to talk about prostate cancer. Additionally, while we're going through this, there's going to be some slides that show robotic surgery. And that same robotic surgery can be used for women's health issues. And, some issues such as pelvic prolapse. And we've got some pamphlets back in the back on that. And that's just where the vagina kind of begins to fall out, through its opening. And that happens with age. And the robotic procedure can be used to fix that. And that's a day surgical procedure. Additionally, I'll show like a little shot of a robotic procedure being performed for a large kidney stone. And so women develop kidney stones. Additionally, for kidney cancer, historically we used to remove the whole kidney whenever someone had a small tumor. Now we can go in and robotically or laparoscopically just remove a small portion of the kidney and just take out just the tumor. So since women and men both develop kidney tumors, that's another way that the robotic type surgery can be used for women. But today we'll talk about prostate cancer. And so what I was going to do was talk about prostate, tell you a little bit about what that is, prostate cancer, also talk a little bit about robotic prostatectomy. And during that portion of the talk, I'm going to show some videos of actual surgery. So if you've got a weak stomach, I'll give you a warning. You just close your eyes real quick. That's what my mom would do anyway. And then I'll show some outcomes data on how robotic surgery can really help us provide better outcomes, for patients with prostate cancer. And I'll show some of that data from where I started the first robotic program was in Shreveport, Louisiana, back in 2003, and kind of show how we changed the margin positive rate, and I'll explain some of that to you as we go along. So, first, what is the prostate? And I use this slide frequently. And it's the largest of the secondary male sex organs. It's about the size of a walnut normally. Its real function is in reproduction. But the thing that's really interesting, this is where the prostate is that it's the most common site of neoplastic change. Or whenever men, the two most common neoplastic conditions, it's BPH, or benign prostatic hyperplasia, and also prostate cancer. So those are the two most common neoplastic conditions that affect men. Now, it's also interesting that only 2 species in all of God's creation develop those 2 conditions, men and dogs, male dogs. So it's kind of you wonder, are we closely linked to the dog? So maybe we're not pigs, we're more like dogs. Now, there's some theories on why that occurs, and some of it may be that the dog was the earliest thing that was domesticated, so it has, shared the food scraps that men have had, from the dawn of time, and they might have developed some of the same genetic hits that men developed, and that's why it's the most common. That's why only those 2 species develop BPH and prostate cancer. So what is prostate cancer? Well, it's the most common cancer that affects men in the United States. Roughly 1 out of every 6 men will develop prostate cancer during their lifetime. There are over 200,000 cases of prostate cancer and about 26,000 deaths each year. Now, the risk factors for prostate cancer are age, diet, family history, and race. So if someone lives long enough, virtually all of us would develop all males would develop prostate cancer. So age is one big risk factor. Diet, anything that's bad for your heart in general is going to be bad for your prostate. So diets high in saturated fats, those kind of things are going to be bad for it. Anything good for your heart is usually going to be good for your prostate. Family history, if your husband or if he had a brother or an uncle or a first-degree sibling that developed prostate cancer, then they're going to be at risk for it. So those are the patients. So it's similar to breast cancer. If your sister was, had breast cancer, or your mother, then that puts women at risk for it. So it's the same thing for males. race. Typically, black males tend to develop prostate cancer at an earlier age, and it tends to be more aggressive, than Caucasian males. And that's why it's important for black males to be screened at an earlier age, usually at age 45, as opposed to white males starting screening at age 50. Now, if a black male has a family history, I would move that back and tell them they need to start screening at age 40. So how do we screen? What we do is we check the prostate by palpating the prostate, feeling of it. And what we're feeling for is any hard nodules or bumps on the prostate. Also, we do a PSA blood test. And PSA stands for prostate-specific antigen. And that's nothing but a simple blood test that they can have drawn. And what we're going to look at is what the absolute level is. And normally, a PSA should be less than 4. So 0 to 4 would be normal. But it's also important to look at age-specific ranges. So some men, as they get older, we may tolerate a PSA of 4, but, and again, for a young male who's 45, we really want their PSA to be down around 2.5. Also, it's important to look at the change in the PSA. So how does it change over time? If somebody came in, their PSA 1 year is 0.5 or 0.5, and the next year it comes in and it's 1, well, that's worrisome because it's doubled in 1 year. So what we may want to do is, I'm not going to necessarily recommend doing a biopsy then, but I would recommend having them come back and let's check it again and see if they're still having the same trend where it's going up. So the important thing from this is that your husband, son, brothers, men in your life need to be screened for prostate cancer, and they need to see a urologist, have their prostate checked once a year, and also have a blood test, a PSA done once a year. So after we see someone, they've got an elevated PSA or they've got a prostate nodule, what we're going to do is we're going to recommend doing an ultrasound-guided biopsy, and all we do there is we put a probe into their rectum, and we use ultrasound to take pictures of the prostate, and then we fire a needle into the prostate. We usually do this in the office under local anesthesia, and we get these little tissues of core, little cores of tissue, and that's prostatic tissue. And the pathologist looks at those under the microscope, and they look, 1, do they have cancer? And then 2, they try to grade the cancer and tell us how bad the cancer is. And they grade it using what's called a Gleason grading system. And so you'll hear that, and they score it. They score 2 areas on the slide, and they'll score it 1 to 5. And so you'll get a score that is the sum of those 2. So you'll get, someone would be told that they had a Gleason grade 4 cancer. And that just means that it had 2 areas. One was a 2 and another one was a 2. So that would be a Gleason 4. Gleason grades 2, 3s, and 4s are low-grade cancers. 5, 6, and 7s tend to be medium-grade cancers, and 8, 9, and 10s are high-grade cancer. Now, why that's important is that higher-grade cancers tend to be much more aggressive and more likely to metastasize and spread. Lower-grade cancers are less likely to do so. So after we do the PSA and we do a biopsy, we find out that someone's got prostate cancer. We then try to stage it and tell us, is it localized or not? And the kind of things we look at are listed here for staging the cancer. And so we stage it using all those, a piece of information. Now, treatment options depend on a couple of things. One, it depends on the age the person is and their state of their health, and also the stage of the disease, and also their personal preference. So if a patient looks like they've got a life expectancy of 5 or 10 years, then we may, or less, we may only recommend observation, where we don't do anything. And we may do that based on the fact that, prostate cancer may be a slow-growing cancer, and they may die of something totally unrelated during their life. But a lot of that comes down to personal preference, because a lot of patients do, even when they have a life expectancy of 10 years, they may be worried, during those 10 years that they've got this cancer growing in their body, so they may want treatment. Now this list just shows all of our treatment options, and this list continues to grow every year. And so observation is one of those. Active observation just means that we draw we do repeat biopsies over time. So like someone may be diagnosed with prostate cancer, and they elect to do active observation, not have any treatment, but we do a repeat biopsy. Maybe they only had one biopsy that was positive, and we did 12. So they're following it. So next year we do another biopsy, and they still only got one biopsy that's positive. Well, that's still a low volume amount of cancer, so we're following that. So they come back a year later, and now we've got 4 or 5 cores that are positive. So then we may start some other treatment because they're progressing. So that's how active observation works. Radiation therapy can be done by either external beam, where they shoot the photons through the person to treat the prostate cancer, or it can be done by putting these little radioactive seeds into the prostate. You can have the prostate frozen. It can be heated up. You know, they've got all different options now. And surgery. And surgery can be done by a variety of techniques. An open surgical procedure where you make an incision on the stomach or around the perineum, around the anus. It can be done laparoscopically with laparoscopic little ports going through. Or it can be done with the robot. And the robot is actually a laparoscopic prostatectomy, but you know, it's different from a classic laparoscopic surgery, and I'll kind of explain why that's different in a few moments. But the goals, if someone undergoes a radical prostatectomy or surgical treatment for prostate cancer, we've got kind of 3 goals that we're trying to cure the cancer first, but also issues that affect the quality of life of men, or their ability to achieve erections and still be sexually active. And then also continence, where they're not leaking urine on themselves. And those are 2 other issues that are really important. So our goals are really to cure the cancer, preserve their ability to get erections, and also preserve their continence so that they're not leaking. Now, this slide shows how patients do after radical prostatectomy. And this comes from a public national database for doing open radical prostatectomies, and this was several years ago. Most patients stayed in the hospital about 4 to 5 days. Almost half of the patients required a blood transfusion, during surgery. Incontinence, having to wear 1 or more pads, almost 40%, or 4 guys out of 6, were required to wear pads after undergoing surgery for prostate cancer. Only 17%, or let's say roughly 2 guys out of 10, could still achieve erections after having this type of surgery. And almost 25% or 26% had a positive surgical margin, where the cancer grew right up to where they were cut when the prostate was taken out. So why that's important is that almost half of those patients will fail. Their cancer will come back over time because of the positive margin. So clearly, I think all this data showed that we had a lot of room to improve treatment for prostate cancer, and this was back in 2003 when I first, made this slide. So what came down was laparoscopic prostatectomy, and the slide that I just kind of jumped past was a traditional laparoscopic, prostatectomy. And what that means is, you all know what laparoscopic surgery is: keyhole surgery, minimally invasive surgery, and it's where you put laparoscopic ports through the belly instead of making a big incision. When I was at Duke as a resident, I went to all my fellows at Duke and asked, or all my attendings at Duke when I was a resident, asking them, what about, this was back when gallbladders first started in the late 1980s, and I wanted to know, could we start doing laparoscopic prostatectomies? And everyone kind of laughed at it and said, there's no way you can do a laparoscopic prostatectomy, so forth. So my roommate was a general surgeon, Robbie Chari, so he and I went to Ted Pappas, who was a general surgeon, and said, hey, look, we want to see if we can work out how to do laparoscopic prostatectomies in dogs, since dogs were the model. And he said, great, sounds like a good plan. He gave us money and just said, go to work in the lab. So we went to work in the lab, and we wrote the first paper doing laparoscopic prostatectomies ever, back in the 1990s. And of course, it was so hard to do. I never wanted to do one on a human because even then, we did 6 or 7 dogs, and they took like 8 hours to do the first one. And one of the dogs died from a complication after surgery. So it was not something we really wanted to try on humans, you know, when you had one dog dying from a complication. Plus, there were no attendings at Duke that were interested in doing it. Well, fast forward through that, the French, about 2 or 3 years later, in Paris, they read that paper, they started doing laparoscopic prostatectomies. And lo and behold, they did 100 of them. They had a lot of complications, but they were able to do them. So they did 100 laparoscopic prostatectomies. My attending, by then I'm on staff at Duke teaching. He comes back to me and says, look, why don't you go to Paris and learn how to do this and start doing these here. And I had no interest in doing it. I didn't want to do it because, one, it took so long to learn how to do that operation. And you were going to have bad outcomes and, you know, complications and so forth. So I had no desire to do it. So later I'm back now, I'm in private practice, and I read an article about the Da Vinci robot. So the Da Vinci robot is a way of doing laparoscopic surgery, and it can help you do complicated laparoscopic procedures that normally you can't do with traditional laparoscopic instruments. So if you think about things, when we do laparoscopic surgery, it's like operating with chopsticks. Okay? You put these straight instruments into the belly, and if I want to do anything, I've got to I'm looking at a monitor, so if I want the tip of that instrument to move to the left, I have to move my hand to the right. If I want the tip of that instrument to go up, I have to move it down. And so basically, it's all backwards. It's counterintuitive. And the way we operate in doing complex procedure, you've got to be thinking 10 steps ahead in order to do anything. And at the same time, your instruments are all straight and stiff. And so the only thing you can do is move up and down, left or right. And so if you thought about us trying to operate and do things in the belly just by doing this, that's all we would be doing. So we needed some, advanced technology. And that's where the robot came in. And so it's a computer-enhanced surgical system. The surgeon sits at a console, and the robot stands over the patient and the instrument. It's a master-slave system, so the robot doesn't do anything except for what the surgeon does. So when the surgeon moves his hands to the left, the robot hand moves to the left. And the surgeon operates the console, and you have an assistant surgeon that stands at the table. This is what the console looks like. So the surgeon kind of looks through the monitor and has these little joysticks under, and he's got 4 foot pedals that he uses to change between the ones. This is what it looks like, and this is the surgeon's hands are under the console, and the robot hands are inside. And you see how they bend, and they rotate, and they move. And I'll show you some live surgery in a few moments that kind of shows those hands moving. And again, not like laparoscopic instruments, these instruments move more like your hand does. So it twists, pitches, rolls, has yaw, and all those actions that your wrist does. In fact, it's even got more. My wrist only bends this far, but with the robot, you can step on a clutch, disengage it, and I can take my hand and recock it, and then take my foot off the clutch, and you can go farther. So you can go just round and round in circles. So it's really an advancement over your, traditional, your ability to operate. So it allows surgeons to do much more complicated operations laparoscopically. In fact, if I was to take any of you in here and set you down and ask you to, or try to put you in front of a laparoscopic teaching setup and was trying to teach you how to tie a laparoscopic knot, so just to tie a knot, we'd probably work all day and you'd still not be able to tie a laparoscopic knot. I could set you down onto the robot, show you how to do it, and 6 minutes later you'll be whipping off knots, back and forth. And we did this, when we bought the first robot in Shreveport back in 2003, and the news reporters came in and did that. They couldn't learn to tie a laparoscopic knot, but they could sit down and they could start tying knots with the robot. It took like less than 6 minutes, and they were experts doing. They were doing an expert maneuver. So this is the way it looks whenever we do surgery for the same kind of setup as what it looks like whenever the robot's used to do a hysterectomy, a sacrocolpopexy to kind of resuture the vagina up into the abdomen, or a robot. You have these same little stab wounds that are done. So instead of having a big incision, this is what you end up with. Now I'm fixing to show some slides. So if you've got weak stomachs and are worried, there's not anything bad, but I'm going to give you a warning so you turn your head. But these kind of slides show you what it looks like whenever we're operating. And so this is where the prostate is, kind of right over here. Whenever we're doing this part of the surgery open, typically you make those little maneuvers. You're getting massive bleeding. You've got usually there's a pool of blood here that you can't see through. And with this laparoscopic, or robotic approach, you see that we're able to kind of free the prostate up. We've incised through that. This is where the urethra is, the muscles that control the urination so that they don't leak urine. We're also starting to develop the nerve bundles where we're kind of pushing those off. We're doing that all atraumatically. We're not causing a lot of bleeding. We're not causing a lot of trauma to the tissues. And so overall, that leads to better outcomes, later. So again, you can see it just shows you how the robot arms move and how you can do different maneuvers. This is another so the prostate's all here. This is the main blood supply that usually leads to significant blood loss requiring blood transfusions whenever you're doing a robotic or doing an open prostatectomy. And here we're throwing a suture around it and tying that. Now again, remember that if we were trying to do that with chopsticks, that would be extremely difficult. But here you're able to kind of basically put the robot hands right in position and throw the suture through that. And again, this was I think I've done about 700 or 800 procedures now, and this was when we were doing our first 50, these slides. This is just, again, showing another little part of how the nerves kind of come off. These are not big, white, glistening nerves like you think of what a nerve looks like in the rest of the body. The nerves that are responsible for erections are actually little microscopic hairs that kind of run with blood vessels. And so it's really important to kind of cause minimal trauma. And so what we're doing here is we're dividing the blood supply to the prostate. And this little bundle here is the main blood supply that we're kind of peeling away from the prostate, and we're able to see all this. Now, when this is done open, you're not able to see it. You're basically doing a lot of that by feel. You make some cuts, and then you're pushing. There's a pool of blood that's filling up, and you're not able to you're not able to see what you're doing. Here you're able to see those nerve bundles that are kind of coming off the side of the prostate. Again, the other issue that you worry about when you're operating is incontinence. And so it's really important to spare the urethra. And that's just where the urine comes through. And you'll see we're trying to spare as much muscle around that urethra as possible and not damage that urethra. And so we're able to see all that. Again, when you're doing this procedure in an open fashion, usually that's all covered with blood, and so you never see it. You're kind of doing a lot of that by feel. And so as you can see, this is a much more delicate or operation where you're able to see everything. It's clear. So this is what it looks like 7 to 10 days later. We shoot a cystogram, and we used to do this on everybody. And it just shows that everything's healed. So the prostate's gone. And then we take the catheter out. So the patient wears the catheter about 7 to 10 days. Instead of having a big incision, they've got some little stab wounds, that are kind of healed. So data and outcome. So this is the data from the first 31 patients that we tried the operation on. We finished it 27 times, and it shows you how long it took. So when I did an open prostatectomy, it would take about 2 hours. So all of a sudden, it was taking about 7 hours to do our first one. So it's a huge commitment when you first start these procedures. 7 hours, took a little longer than 7 hours, and then gradually each one of those dots was a prostate. And so it took almost 27 patients before we got over to where it was about two and a half hours. Now they take about 2 hours. In fact, we did one yesterday. We did two yesterday. One of them took about 2.5 hours. One of them took about an hour and a half. So that's just shows that there's a learning curve for the operation that's, at least 27 patients. And to get good margin data, it's really more like about 200 patients that you need to do the operation on. So how do we do curing cancer, continence, and potency, with the robot? Now, when I was in Shreveport, we looked at, we looked at some of that data when we did our first 200. We did that because one of my partners there said, well, the robot's really no better than the open surgical procedure. So I went and I looked at how good was the open surgical procedure in Shreveport. And I looked at just, let's say, one thing. We looked at margin positive. So again, remember the margin positive rate. If you've got a positive margin, you're about half those men could come back and have their cancer come back within 5 years. So that's an important predictor for whether or not the cancer is going to come back. So I looked at the learning curve for what it was like for the robot, and I also looked at what the what the margin positive rate was in Shreveport. A guy named James Eastham looked at Baylor College of Medicine in Houston, Memorial Sloan Kettering. He looked at all these big academic universities, and he saw that at big academic universities, 26% was the positive margins. That's not great, but that's what we should be shooting for. Okay, so Johns Hopkins in Baltimore, Maryland, they've done more radical prostatectomies than any place else in the world, and their margin positive rate was reported on 5,000 patients at about 14%. So really, it would be better if you were down to 14%. So when we looked in Shreveport, we looked at what the margin positive rate was in a private practice group of, it was 15, 16 urologists, and I looked at several individuals, and the margin positive rate was 50%. So it was twice as bad as the big academic, medical centers. And the reason for that was that the doctors weren't doing enough surgery. They were only doing like 12 surgeries a year. Everybody was keeping all their cases and doing very few. So what's really important is you need to be doing you need to be doing close to 100 of these procedures a year in order to stay proficient at it. And that's what that shows. So within the group, I used this information and started doing all the radical prostatectomies there, just about in Shreveport. And then we looked at what we could do, what we did with our margin positive rate in Shreveport was at 50% with a single surgeon. The first year, we down to 37%. And then with the robot, I looked at the first 200 cases that we did. And again, this is Johns Hopkins, 14%, so that's the goal. And so then I looked at the next, I looked at the first 200 with the robot. And on the first, on overall for the robot, it was down to 21% for the first 200. But when I looked at the last 50, it was down to 14%. And so now you see that, by doing with the robot, I was able to, achieve the same outcomes that they were having, like at some of the best, programs in the country, like at Johns Hopkins. So our margin positive rate really came down. And we presented all this at the southwestern section, or at the southeastern section of the urology meeting. And I think clearly what that's showing is that, one, it's a high-volume surgeon, because I was doing lots of surgeries. But it shows how in a community setting you can get the same outcomes that you could get at a big cancer center if you have the right person and programs, kind of in place. And we did this exact same thing in Longview, and when we started a robotic program. And now we're doing the same thing, here in Lufkin. So what are the advantages for robotic surgery for men? One, they have less pain because it's a laparoscopic procedure. We did 2 patients yesterday. They've already gone home, from having a radical prostatectomy instead of being in the hospital 3 to 5 days. Same thing's true for women having hysterectomies or partial nephrectomies or those kind of things. They're going to have less pain, shorter hospital stays, lower blood loss. They get their catheter out quicker. Instead of being in for about 3 weeks, it's going to be in for about 7 to 10 days. Their continence rate definitely is better. I tell men that it's about a 5% chance of developing urinary incontinence. It could be, prolonged, after a radical prostatectomy. I usually tell them 5 to 10%. I tell them that everyone's going to leak initially. And the reason for that is they've got about this much muscle that keeps them from leaking. And after surgery, it's going to go down to having about this much. So it's really important for them to start doing Kegel exercises. And so I start them doing Kegel exercises before the surgery. And that's what strengthens their urethral sphincter. With the surgery, you saw the videos. You're definitely able to spare the nerves. You're able to see them better. And so we're able to do a better job with nerve sparing. So it does translate out into better, erectile function. Cancer control is definitely at least as good. After someone's done over 200 cases, it really looks like it's much better than with traditional open surgery. So, kind of things that I've told you today: prostate cancer is a common cancer for men. They need to have the men in your life need to be screened. They need to have their PSA tested and have their prostate checked by digital rectal exam once a year. There's several good treatment options, but radical prostatectomy using the robot, I think, is definitely the way to go, in 2011. And I think patients definitely have improved quality of life and better outcomes with that type of procedure compared to the open procedure. So I'll thank you. Now I'm going to jump.